A very good afternoon to all the respected judges. I'll be presenting a case series on orbital exenteration. Orbital exenteration is a radical and disfiguring surgery involving removal of the entire orbital contents, including part of the optic nerve as well as the lacrimal gland. Some pathologies also warrant the removal of orbital walls. They may be lid sparing or lid sacrificing. Based on the structures which are conserved, they are classified as subtotal, total, or radical. Basically, in subtotal exenteration, we retain eyelids and part of the conjunctiva. In total exenteration, the eyelids are also resected, and in radical exenteration, orbital cavity bones are also resected. The video on the right side of the screen shows, the video is not playing. Okay, the video on the right side of the screen shows a lid sparing orbital exenteration done in a case of invasive OSSN, and the video on the, sorry, is it playing? Please pause the timer. In and out. Okay. Ma'am, should I continue or should I start again?
Continue from here only.
Okay, ma'am. So the video on the left side of the screen shows a lid sparing orbital exenteration done in a case of invasive OSSN in our center, and the video on the right side of the screen shows a lid involving orbital exenteration done in a case of right rhabdomyosarcoma of the right globe. Okay, coming to my first case, this was a 35-year-old female patient who presented with progressive painful proptosis and diminution of vision. The patient underwent orbitotomy and excision biopsy 6 months ago elsewhere, and she was diagnosed as hemangiopericytoma there and started on chemo and radio, but she was lost on follow-up. On presentation at our center, PL was absent in the right eye with proptosis and features suggestive of panophthalmitis. Upon imaging, there was a soft tissue dense mass in both intraconal and extraconal compartments of the right globe. Of the right orbit. The lesion involved the lateral rectus muscle, and there was a bony erosion in the floor of the right orbit and extension into maxillary sinus. All features suggestive of malignancy. The patient underwent a radical orbital exenteration under general anesthesia, and the socket was left to granulate. The biopsy report showed grade 2 clear cell rhabdomyosarcoma, and the patient underwent radiotherapy for the same, but she reported with recurrence over the wound surface after 2 months. Coming to my second case, an 86-year-old male patient presented with right eye diminution of vision and foreign body sensation. Upon examination, a mass of size 3 into 2 into 1 centimeter was found over the temporal bulbar conjunctiva, which bled on touch, associated with total corneal opacity and an absent PL. Extraocular muscle movements were restricted in the right eye in all the lateral quadrants. NCCT orbit showed an ill-defined lesion in the lateral, involving the lateral rectus and lacrimal gland, abutting the surface of the globe. There was no intracranial extension. After a lid sparing subtotal orbital exenteration, the biopsy report showed a well-differentiated grade 1 invasive squamous cell carcinoma. The patient showed no signs of recurrence or surgical site infection after 6 months of follow-up. The patient is currently on regular follow-up and doing fine. Coming to my third case, this was a 48-year-old male patient admitted to the COVID ICU of our center in June 2021. He was treated with high-dose injectable steroids. He had no previous history of diabetes mellitus. He gradually developed blackish discoloration around the right eye with periorbital edema. We provisionally diagnosed him as mucormycosis, and the MRI showed involvement of the orbital apex and the ethmoid sinus. DNE with orbital exenteration was done, socket reconstruction with titanium grid, and a rotated forehead flap was given. Microbiological study revealed fungal hyphae, and histopathology confirmed it to be mucormycosis. Recurrence occurred in spite of local and systemic amphotericin B, and the mass was excised again. Luckily, he survives and comes for intermittent checkups. In case 1, the patient underwent a radical orbital exenteration, including removal of periosteum, yet she reported with recurrence due to extremely invasive nature of sarcoma, whereas in the second case, a lid-sparing orbital exenteration was done as the pathology was limited to ocular surface. Most common indications are malignancies and necrotizing infections. In 2 out of the 3 cases discussed here, socket reconstruction could not be done due to high risk of recurrence of malignancy. A study by Ko et al. Concluded that although it is an aggressive procedure, it is not unreasonable in well-selected patients. So our take-home message is that the type of orbital exenteration can be customized as per the patient need based on the location of pathology. As a destructive procedure, the aim should be to attain margin clearance so as to avoid further morbidity to the patient. Patient should be rehabilitated with socket reconstruction in cases where possible, and outcomes can be extremely favorable in well-selected patients. Thank you.
What was the final cosmetic rehabilitation you did in one case in which you couldn't
In the first case, ma'am, actually she presented with recurrence, and even there were liver mets as well. So we just gave a occluder over the left eye, over the right eye. We couldn't do much in that case because already she had liver mets and she was undergoing radiotherapy and chemotherapy both. So locally for the exenterated, the anophthalmic socket, we couldn't do much really. Thank you.